Well, welcome back, everyone. Those of you who've been joining us for our virtual UHC Pavilion event so far today, welcome back. Those who are joining us for the first time, welcome anew to a new session that we're focusing on maternal health as part of Devex's overall UHC Pavilion Day on the sidelines of the UN General Assembly. If you've been with us, you just saw my interview with Antonio Guterres, of course, Secretary General of the UN, where we spoke about the Sustainable Development Goals and global health. It was really excellent to get his take on these issues because, in our view, many of the most important issues that get discussed in a General Assembly are the very issues we're talking about today, tomorrow, and the next day at this UHC Pavilion. Global health was always an important theme for us in the General Assembly week at Devex, but at this moment, with a pandemic forcing the General Assembly to go virtual, with all of our life and work severely disrupted, and of course, hundreds of thousands of people dead around the world, now approaching 1 million people around the world who've lost their lives to this pandemic. This is a moment when all of us are thinking about global health in a new way. And one of the groups that really deserves special attention right now are mothers who are expecting, who are giving birth, and the challenges that they face and the gaps really in our health system that they are witnessing right now as this pandemic interrupts the way that health services are provided. So this session is going to dive into that with people who are experts on these issues at a high level and working on it on the ground. You're going to hear some really interesting perspectives from people who are working on this every day. I just want to tell you a few things to orient you as we begin the discussion. First of all, there's a website that you might want to go to, which is unga75.devex.com, unga75.devex.com. Of course, the 75th anniversary of the General Assembly. And this is the place where we're bringing together all of our journalism, our reporting, our information, our graphics, everything you need to understand what's happening at the General Assembly is there, and you can find information relevant to this event. We are hosting, as I've mentioned, a series of events over the course of 3 days here under the banner of our UHC Pavilion. If you've been with us in person in the past, you can imagine a bustling hall filled with global health leaders and practitioners, side events, side conversations, a really insightful day. We've now taken that virtual over the course of 3 days. If you're following us on social, which I hope you are, you can follow us at Devex. You can use the hashtags UNGA75 and Maternity Matters, hashtag Maternity Matters. We've got a chat box here on the Hopin platform. Submit your questions there. You can submit them during the course of the conversation today. This session is hosted in partnership with our longstanding partner, MSD for Mothers, known by many in the United States as Merck for Mothers. MSD for Mothers is one of the leading organizations and platforms focused on this issue of maternal mortality. The overarching theme today, if you look at the headline that you saw there on the slide, maybe we've packed more acronyms into one title than anyone else during the UN General Assembly week. We win the award for that. It's Bridging the RMN-CAH Gap, of course, reproductive, maternal, newborn, child, adolescent health gap. Delivering UHC for mothers in the era of COVID-19. That's what we're here to talk about today. And this is building on a series of conversations that we've been doing over time. Some of you have been with us along the way for these conversations. We're working with MSD for Mothers really to understand how the private sector and government can work together to help fill these gaps. The dollar amount that's often used is $33 billion is the funding gap that's affecting this RMN-CAH area. But we want to talk about how do we actually close that gap? How do we find solutions? And we have together been doing this over many months and a few years, really moving the needle on this conversation. We're going to do that again today. And we need your participation to do that. There are some poll questions. There are the opportunity to add your questions to the conversation through the chat. And of course, follow this on social media and amplify it. We're going to start by getting a view from the ground, from somebody who's dealing with these issues every single day. So I want to welcome Dr. Jyoti Bove from India, from Navi Mumbai, to join us, if she can turn on her camera. There you are, Dr. Jyoti. Dr. Jyoti is someone who has been dealing with the effects of this pandemic while trying to provide care as a gynecologist and obstetrician to women in her community. And you can imagine some of these challenges, what they have been like if you are an expecting mother and you need to go in for prenatal checkups, but maybe your health facility has been closed due to the pandemic or the resources have been shifted. We're going to get into that with Dr. Jyoti today. Welcome to the conversation. We may have lost her temporarily, but I'm sure she is on her way back. So let me just say a few more words as she makes her way back. What many women are experiencing is perhaps akin to what we saw in the West African Ebola crisis of 6 or 7 years ago now, where tragically some 11,000 people lost their lives from Ebola. But many more actually died or were severely impacted by other health crises. People couldn't go to their regular health facility to deal with malaria. They couldn't go to deal with cardiac issues or other non-communicable diseases. And they couldn't go to deal with maternal and reproductive issues. And those realities caused many more people than died from Ebola to experience severe health consequences during that crisis. Something similar is happening today during COVID-19. And we're going to explore that a bit more, particularly looking at this RMN-CAH lens. If we're unable to get Dr. Jyoti in, I think we're going to move directly to our video remarks. We have a video which will help to set the stage, and then we'll bring Dr. Jyoti back in as we address the technical issues that may be happening here. So let me ask our producers if they can to cue up a video that we have from Dr. Jaideep Tank, who is based also in Mumbai, Maharashtra state in India. He's the Secretary General of FOGSI, which is the Federation of Obstetric and Gynecological Societies of India. We're going to hear his message, and we'll come back to Dr. Jyoti and then to our panel in just a moment. We are back. As you saw there, the video was proceeding, but we couldn't hear. So we're going to give that one a try again in a few moments. For now, I'll see if we have Dr. Jyoti with us. And if her connection has not worked, I'm going to just move directly to our panel. And it looks like it has not. So I'll ask our panelists to turn on their cameras if they will, as I mentioned who they are. And we're going to just dig right into the conversation. When we get back Dr. Jyoti, we will bring her into the discussion too. Let me welcome David Clark, who is the team leader for UHC, Universal Health Coverage, and Health Systems Law at the WHO. Dr. Gitinji Gitahi, my friend, Group CEO of AMREF Health Africa and co-chair of the UHC 2030 Steering Committee. Welcome, Gitinji. Dr. Monique Vletter, who's the practice manager at the Global Financing Facility, GFF, as many of you know it. Welcome, Monique. And my collaborator, co-conspirator, fellow, showman on the stage all over the world, Dr. Marianne Etiebet, who is the lead and executive director at MSD for Mothers, and a real leader on these issues. Marianne,
and my dog.
To you too, and your dog. Yes, this is as I said, it's going to be much more exciting than what's happening in the official sessions over at the UN. You don't get that there. Welcome all of you. As we begin the discussion, I gave a little bit of a preamble, and of course we missed hearing from Dr. Jyoti on the ground, but we'll get there. What I want to hear from all of you is what you think the pandemic means for maternal health and for the RMN-CAH issues, what you're hearing from around the world. And I thought maybe I could begin with David. Since you're at the WHO, you're seeing this at a high level. And as I say, most of the attention is on COVID, but there are many other health issues. What do you expect is happening out there? What do you see is happening out there from a bigger picture global health perspective?
It's a bit patchy, to be honest, Raj. So one of the things that I focus on is private sector engagement. And even before COVID, we saw that a lot of countries were struggling with private sector engagement. And why this topic is important to WHO is because we recognize that in a lot of middle-income countries, the private sector make up most of the health system. They're providing lots of health services. So if we're going to get ahead, if we're going to achieve universal health coverage, and if we're going to effectively respond to the COVID situation, then it's critical that countries work constructively with the private sector. So that's my starting point. Even before the COVID situation, we saw that some countries were really struggling. And what COVID has done is really exasperated the situation. And what's made matters worse, I think, is quite rightly, we put a big emphasis on the need to deal with the actual immediate response to COVID. But another aspect to that, of course, is the need to maintain essential health services. And what's happened, I think, is that we've lost sight in some places of the need to maintain these services. And as you said in your opening remarks, make sure that people continue to have access to health services they need. Otherwise, post-COVID, we're going to have a big mess to clean up as we try and deal with all these unmet health needs, which have been put on hold as a result of us focusing on so much on COVID. So a lot of the work.
It seems already cleared. Doesn't it seem already clear to you, David? We are going to have a bit of a mess here. I mean, yes. You can see the statistics on the number of people who are going in for cardiac or non-communicable diseases, and the numbers are very low compared to what would normally be the case.
Yeah,
because the health facilities are closed. They're scared.
That's right. That's exactly right. And focusing on the private sector aspects of that is that different countries have taken different approaches to working with the private sector as part of the response. Some of them have closed down private facilities. And in those countries where people rely on the private sector for their health services, even the poor, then they haven't got access to health services. So it's a big problem. What we've been trying to do here is emphasize the need for a whole of society, whole of health system approach to COVID and to maintaining essential health services. And that means working to make sure that you bring all the health providers into the response, not just the public ones, but the private ones. But that raises a number of challenges that we can go into if you want.
Yeah, let's come back to that in a second. I want to bring Marianne in, since you started out, David, on private providers, because there's a myth here that you've been trying to bust for a long time, Marianne, that private providers are really a niche segment meant for the wealthy. And I think often the challenge is we bring to these conversations our own experience wherever we might live. But in many of the largest countries in the world, in terms of population, many middle-income countries and low-income countries, private providers aren't for the rich. They're actually the common way people get access to healthcare. Yeah. So David's point that if we don't pay attention there, we might be missing on the question of how people get access to essential healthcare is really important. Maybe you could just pick up on how you see the private sector fitting into this conversation.
Thank you, Raj, and thank you, David. And you're exactly right. I mean, in some communities, private sector, local private providers are the only healthcare providers in that community, whether it's the local midwife or the local community pharmacists or patent and proprietary medicine vendors. And one of the things MSD for Mothers has been trying to do is make sure that we can support the integration of local private providers into national health strategies, for them to be actually contributors, to national and global health priorities. And so how do we do this? We make sure that they have the tools and platforms to be able to provide high quality care. There's connectivity, so that they can link with, with public sector. What's really exciting in this conversation with regards to UHC is the huge opportunity to link the financing schemes, the health insurance schemes that have been catalyzed by UHC to local private providers so that they can be part of the provision of care and increase availability and increase access to care in ways that are affordable, for lower income populations.
Yeah, and of course, it ties into the question of quality, right? Because you often have private providers who might be very strong and others who might be very weak. And if they're not integrated into the system, there's no way to address those quality imbalances. That's a key theme we'll get back to. But I want to bring Dr. Gitanji Gatahi into the discussion if I can. Gitanji, you bring a unique perspective to this, because at AMREF, you're looking across many, many countries, I think 54 countries across Africa, and you yourself have a private sector background. I guess, what are you seeing when it comes to how the pandemic is interrupting healthcare services, and then particularly when we think of maternal health services? What are you seeing as the challenges and maybe the opportunities today?
Thanks, Raj, and appreciate all the comments made by David and Marian. I think the first thing we need to remember is that the COVID crisis is not a health crisis. It is actually beyond the health sector. So it's a social crisis where we are seeing rising gender-based violence. It's a social crisis where we are seeing rising teenage pregnancy. It's a social crisis where we are seeing mental health issues with women, and especially pregnant women, because of the challenges they have to face economically, while at the same time carrying through a pregnancy. The next thing is an economic crisis, and the economic crisis also contributes also to those other crises I talked about, because most of the gender-based violence is related to economic challenges of people who have to stay at home and they can't go to work, they don't have food to eat. So it's actually been a very expansive challenge, Raj. But let me reflect on the life of a mother who is pregnant. For example, if we were just to take reproductive health services, there is actually, in terms, if you had to look at it from that mother's point of view, there's no private and public health system. In fact, I am not sure that I know a mother who actually attends all her services in the public system or in the private system itself. Because what you find is that if a mother is pregnant, the first private provider the mother will see is a community health volunteer. We often don't put them into private providers, but they are actually private providers, especially when they are unemployed and they are volunteers. They are providing service to those mothers at no pay, or they are providing services to those mothers to be paid in kind, in chicken, or maybe in a favor here and there. So that's the first base of providers, private providers we find. Now, as you move forward, the mother then may visit the local health center, which is a public health center. But the mother may require an ultrasound, and the health center doesn't have an ultrasound. So the mother will go to a private ultrasound provider, pay for the ultrasound, and then come back. And then later we'll be told, you know, we need your antenatal profile. We need you to do this test. You need to do urinalysis, hemogram, but we don't have the following reagents. Why? Because, as Marian said, we don't have a properly working health insurance system. And also you may find, I've visited some health centers, Raj, where, you know, there is an insurance system, but the funding mechanism is so broken down, an autonomy or, you know, of facilities to access their own funds to respond to the needs of their clinic, that they may have the funds, but they can't purchase reagents. So the mother still has to go to a private laboratory to buy. So basically, when you're talking about reproductive health services, it is one system. It is one mixed system. It's not this mother private, this mother public. Now, what we've seen as we go along is that therefore the crisis that's socio-economic and and all the other factors that are in there has impacted mothers significantly. So what we find is that on one side, family planning commodities are not available, and therefore they have had to actually order them from community health volunteers who can probably find and bring to them at a small fee. We find that when mothers need to go to the clinic, one, there has been fear of infection, but even beyond that, you know, at a certain point, the fear is overcome by the fear of losing your own baby. So you decide I have to go, but you can't go because there is curfew, because there are policemen, and you've seen the level of police brutality actually in many of the countries that we've seen, where when the curfew started, the police didn't want to reason with anyone. You say you're pregnant, they say, no, go back home. So the mothers develop fear, because no mother wants to be clobbered by police trying to go through a police barrier. So what we did then is to start now engaging with some of these challenges and bringing in private sector. On one side, the providers I talked about, all the way to community health workers or community health volunteers, training them through technology, training them to provide service, training them to continue essential services at whatever payment mechanism exists, because they're not paid by government, you know, whatever households can afford, but training them to continue. That was number one. Number two is we have seen that working with taxi hailing companies, we started an initiative called Wheels for Life together with other partners like Kenya Health Federation, where we worked with a taxi hailing company called Bolt to actually provide safe passage for mothers through the curfew, through police barriers, where the mother would call a hotline, and we had thousands of calls and say, I think I may be in labor or I need to go to a facility, and they would be connected through that hotline to this taxi hailing company. It would collect them, take them to, and they had clearance from police to travel beyond curfew hours. So these are just some of the things that we are seeing in terms of the challenges and how we are trying to resolve them. But generally, I would like to say that it is both it one mixed health system. It's a fruit salad of public and private together, and facing the challenges and then having to engage private sector players to resolve these, not only in transport, but also in financing. We have also engaged private sector. For example, I have seen Jacaranda Health, one of the private providers in Kenya, using artificial intelligence because they have huge number of women they take care of. They are using artificial intelligence to provide the bots to their phones so that if they have issues around, is COVID going to affect my baby, they can actually get, all these answers. So it has been a huge effort. We are still not there because we don't have the data to tell you this is how it works, this is how it, we have anecdotes and we have projects. Right. We don't have coherent data to give you the answer.
But the anecdotes are so important here, Gitanji. I think the way you framed it is critical because we have to see it from the patient's perspective. And certainly many of the people on this panel worry about this at a global or regional level. You're thinking about health policy. But at the end, the patient has to access the services that she needs when she needs them to save her life and her baby's life. And that is so essential. And there's no way to get there without engaging the health system as it is today, which, as you say, is a bit of a fruit salad. It is a mixed bag. And I want to bring Monique into the discussion because you have to figure out, Monique, how to address the funding gaps in a system where, in a place like Kenya, where Gitanji is based, I think it's 65 or 66 cents on the dollar that people, 66% of healthcare expenses are out of pocket for people, as in many other middle-income countries. You've got to figure out how do we bridge the gap for the mothers that Gitanji's describing, this $33 billion gap I referred to at the very beginning, using the financing mechanism that you all innovated at the GFF. So what is your take on how you do that, how you bring in the private sector, and maybe as well what the COVID situation means for your work at GFF?
Great, thanks Raj, and thanks for the opportunity to speak, and it's great to see you. I remember the panel and our lively discussion in person last year, and I miss having all the friends around that are on the panel. I want to build on something that Gitanji was saying, because I think his point about that this is an economic crisis, socioeconomic crisis is really important. And what we see across GFF is operating in 36 countries, is that women are really disproportionately affected by this crisis. We see an increase in gender-based violence. Schools are closed, and so it's hard for women to work with the caretaking responsibilities. There are job losses, etc. And so it really is a really broad crisis. And we looked in collaboration with 10 countries. We looked at what is the impact on the access to essential services for women. We just published a press release last week that shows that there's substantial decrease in women accessing services. There's a lot of variation between countries and also a lot of variation between services. But we see particularly that outpatient care and vaccinations are very much affected by this crisis. And so I just want to put that out there, that data has been incredibly important for us to then, through a virtual platform that we have, engage with countries and look for solutions of how to address this.
And that gets to, sorry to interrupt briefly, but that gets to David's point earlier that, if people aren't getting their vaccinations now, we are going to see a further problem, a further explosion, a real challenge down the road. But please continue, Monique.
Yeah, exactly. And we think that a response to that cannot wait, right? And so we're trying to understand better what are some of the barriers. A lot of the barriers are around lockdowns, like Gitanji was describing, but there are also very severe financial barriers, right? And so then what are the opportunities in a situation like this? And so we set up a virtual platform, was part of our normal community of practice to bring countries together, ensure that we can have conversations on the basis of these kind of the really high quality data and assessments of how do we address this. And when we talk about those solutions, we think about mixed systems, right? And how do we take best advantage of the presence of public as well as private service providers? How do we work with those providers to ensure that when we look at what is the type of protective clothing that is needed, we take into account the private providers just as much as the public providers. When we look at the mix of services, if it's hard to access family planning, for example, in a public facility in a certain location, can it be accessed by going to local private pharmacies, right? And so really thinking about the mix of public and private services in a really comprehensive way, and jointly in conversations with the government and the local partners, ensuring that we really see the system as mixed. I want to bring up one other thing as well, which I think is very, very important. We do need regional and global strategies as well. We see very severe interruptions in the availability of commodities that are essential for the delivery of quality services. This is, for example, due to lockdowns in India, and a lot of African countries are dependent on the production and the supply of commodities for maternal care that come from countries that are also under lockdown. And so thinking in the medium to long term around having more sustainable solutions and less dependency for African countries on those global supply chain is another really important area of work, where we're working together with the private sector arm of the World Bank to see whether we can support and encourage and incentivize local production of those commodities that we know make a huge impact on the health outcomes for women.
Yeah, the pandemic's making us think in so many new ways about UHC, including things like supply chain resilience and things like having the right, financing mechanisms at the country level, health insurance plans, and having strong health systems that can withstand this pandemic, the next one, and still be able to provide services along the way. If the panel will indulge me, I do see that Dr. Jyoti is with us, and I'm always worried that we may lose the connection. So if she's here and can put her video on, I might just bring her into the discussion right now, if that's okay with all of you. We'll give it a try. Dr. Jyoti, if you're hearing us and are able to, please turn your video on and join our conversation. Dr. Jyoti, I gave a little bit of an introduction to you before, but you've been an obstetrician and gynecologist for, I think, 28 years now. You're practicing in Navi Mumbai, which is outside of Mumbai, a huge urban area. And I just want to hear from you what you're seeing. What are your patients seeing? What are you seeing as a medical professional right now?
Actually, because of lockdown there was problem. Patients were not able to reach to hospital. That was one thing. Then there was containment system, because wherever there were many patients, that area was totally sealed up. So it was difficult for patients to reach the nearest hospital also. And patients were apprehensive initially. Even doctors, we people were also apprehensive because we were totally new to this virus. Secondly, afterwards, patients started taking appointment by either by telephone or video consultation. But there the problem started, as Dr. Monique has said. Patients were missing vaccination, then anemia got undetected, then signs of pregnancy-induced hypertension were missed. Then there were other problems like early complications were getting missed. Patients were getting infected, but they were not ready to come to hospital. That was the problem, and they were afraid of coming to hospital only. And in India, there was another problem because there were many hospitals which were converted into totally COVID hospitals. So even patients are not sure whether they are going to particular hospital. Whether it is COVID hospital or non-COVID hospital, whether the doctor will be able to treat them or doctor himself or herself is quarantined. In that case, the facility will get temporarily closed, and patients will be again totally confused and scared. And in fact, sometimes it even happened that patients were not even sure that they will be delivered by that particular doctor. Means
so in your facility, Jyoti, what have you done to try to address this? What are some of the measures you put in place?
Actually, what happened, our Foxy has Manyata training protocol, and as per that, my staff was trained. Means they were trained for infection control protocol. Even I got trained myself, and because of that, we were very sure about the quality. Means we were sure that we will not get infected ourselves. Secondly, we will be able to give proper treatment, quality treatment to the patient. So we moved to digital very fast as per our Foxy guideline. We stopped doing non-urgent surgeries and we concentrated totally on the emergency aspect, like deliveries and abortions and everything. So whenever a patient called to hospital, we took brief history, like a history of fever, throat pain, or maybe a history of immediate family member having a suspicious history of COVID. in the neighborhood and all that. Everything was done by phone. And after that, once patient gave proper history, patient was called to hospital. And at the entrance itself, we took temperature by IR. Then hands were sanitized. Wearing of mask was totally mandatory for the patient. And once the patient entered, we divided ourselves in different teams. Means few sisters were there who took pulse, blood pressure, temperature, weight, and other things. Then I did examination, and another sister collected blood sample for investigation. But I made it a point that each and every patient will spend some time with me, because what happened, because of this pandemic, everyone was so scared, and especially the first timer, they were not aware about the disease itself. Secondly, they were not no, they were not even aware about anything, means like pregnancy with COVID complications and everything. So, and after that, we came to know that whatever time I'm giving, even that is not sufficient. So we again moved to digital thing, because patients were not ready to come to hospital on regular basis. That was one thing. Secondly, even we were not calling patient, because first visit was at the diagnosis of pregnancy, then at around 12 weeks, then at around 18 to 20 weeks. At that time, we ensured that patient takes vaccination. Then then fourth visit was at around 26 weeks.
I think we may be starting to lose Jyoti a bit here, so we can turn back to our panel. But you've gotten at least a good taste from her of how challenging the situation has been for medical professionals who are trying to provide services.
Really difficult for us also,
public and private providers.
But the thing is, we came to know that there were patients who were missing vaccine.
Yeah, I'm going to just ask our producers if they can mute her until we get her connection back correctly. And I'll turn, if I can, to you, David, to just get your take now. You've heard from many of the other panelists, to get your further take on these issues.
Well, I just wanted to talk a little bit about some of the work that we did to try and get a better handle on some of these issues. When the COVID response started off, we thought it was really important to have a look at how countries were actually interacting with the private sector, because we recognize, as many of the speakers have spoken about, that we are talking about managing mixed health systems, not just public systems. And we found that there were 6 major policy challenges that most countries were facing. The first one was that many countries were just completely unsure how to involve the private sector in their response efforts. They had no idea. Those countries who had existing private sector engagement mechanisms, because they had public-private dialogue platforms, because they had contracting mechanisms through social health insurance schemes, they could integrate the private sector really quickly. But a lot of countries, particularly in Africa, don't and didn't. And that
shows how important it is to have those things set up before a pandemic.
Absolutely. And then the other thing I wanted to highlight was, you mentioned before, the issue of data. And what we've also found is, in many countries, there is terrible data about the private sector. We did a big study last year, I think of about 80 countries, to try and get a better sense of what sort of services the private sector were providing and who was seeking those services, including looking at income quintiles to see whether or not it was just the rich or whether it was the middle income people and the poor. And it most certainly is across the board, and the poor do seek services in the private system. The other thing is that, and the thing I think, as Dr. Jyoti was saying, sometimes the private sector lacks the key inputs it needs to provide an effective response. We've found that a lot of private providers have been saying to us that they haven't had access to equipment, personal protective equipment, or access to things like the public sector's referral and clinical coordination mechanisms. So they've really struggled to work with the public sector. We've also found problems with legislation. We've also found problems with countries struggling to work out how to reimburse the private sector for services. If you want the private sector to start to provide more and more essential health services to take up the slack for the public sector who's working on the COVID response, then you really need to be able to pay these guys to provide the services that you need to produce to provide services for women and other underserved groups. And the last thing,
danger, if you don't, David, is that it becomes a higher out-of-pocket expense.
Yes,
that could push people into poverty in a crisis like this.
Absolutely, and for us, one of our key priorities is achieving universal health coverage. So this is something that we care about. And then the last thing that we've been working on is this whole question of the private sector not having access to revenue, because they're in some cases they've been stopped from providing services. It's a real problem that some private sector providers may go to the wall. Now, you might wonder why WHO cares about that. Well, WHO cares about that because it wants to make sure that the poor and others continue to have access to health services during this critical time and also post-COVID. So we're looking very, very closely at we're doing a study at the moment to see what that means. If we do have large numbers of private providers getting into financial difficulties because of this situation, what does that mean for our efforts towards providing services to mothers and children now? And what's it going to mean post-COVID?
Let me just dig a little deeper into this data question with Marianne, because I know this is something you've talked about before, and we've worked together at Devex and MSD for Mothers to try to find more data on what many of the international organizations are doing when it comes to the private sector and health. And it is hard to find that information. It is not easily accessible. Why does data matter so much in this debate, in this conversation?
I think data matters because it becomes an enabling tool. I think a lot of the challenges and obstacles around public-private sector partnership, are not necessarily based on fact. And so the more that we can actually bring data, to the issue, we can understand the realities on the ground and actually solve for what's happening and be responsive to the women and clients. One thing I do want to add to the point is, I think with COVID, we have all experienced that where there's a will, there's a way. And all of the things that David just mentioned around some of those obstacles and challenges to effective private-public sector partnership, let's make sure that we take those, we share those, whether it's through the GFF networks or other networks, so other countries don't have to reinvent the wheel. And in a post-COVID world, we can continue with these partnerships that we are seeing have impact right now. One of the things that I do want to impress is that this sense of urgency that we are all experiencing in COVID, it should have existed before, and I really hope it exists after, because to get to that 2030 goals for maternal mortality, we really have to accelerate our progress. And it's only by working really closely across sectors, including non-health actors, that we're going to get there. The other thing that we are realizing with COVID is, Githinji mentioned, the challenges around transport. Again, they existed prior to COVID. If you actually dug into the data around maternal health, most of the deaths are happening when women are getting transported from one level of facility to the other. So how is it that we take the experience, from working with private sector transport companies to make sure that, women don't fall through the cracks, as they get transferred from one facility to another. The other thing I'd like to add around the data point is we've recognized with COVID that this two-way communication makes a difference. Githinji mentioned this is also a social crisis. There's anxiety where folks are living in a vacuum and don't have information. And so when you have some private sector providers or facilities that were able to share information with their clients and have their clients actually ask questions, so it wasn't just, generalizable information, but information specific, to a woman's case or her situation, you're really able to continue with that sense of connectivity that at least we've heard from our partners, made a difference. So how do we continue with that sense of connectivity, and how do we take the data that we're learning from those conversations around what women want, what they need, what works best for them? How do we take that forward in a post-COVID world? And then the last point I just want to make, because Monique touched on this, and I think it's so important. We say COVID doesn't just take lives; it takes livelihoods. when we involve local private sector in our responses to COVID, we're actually supporting the revitalization of local economies. And so as we think of our responses, let's make sure we're investing in the local social entrepreneurs that are bringing innovation to this issue. Let's make sure that we're investing in strengthening the capacity of local private sector to provide high quality care and to integrate with public sector, because we need to be smart. We need to make sure that our response is having a multiplier effect, because back to that original question you had around, there is a financing gap. COVID has only widened that gap. And so, each dollar, each shilling needs to go further, needs to work smarter.
Yeah, those are great points. Another thing you're not going to get at the official UNGA sessions is my daughter peeking her head into our live event here. I do want to mention you're talking about two things that are sort of connected. One is this idea that we have all created a level of urgency. I mean, I've seen this across public and private. All the institutions that you all represent are working at a pace and breaking down red tape and bureaucratic barriers in a way we've never seen. Because of the importance of this pandemic. And yet, for many people, like taking that patient focus Gitinji, started us off with, they've had a health crisis every day of their lives now. They've been suffering these challenges in many different ways, whether it's an infectious disease or whether it's trying to get access to basic essential medical services and they can't. How do we translate? Marianne got us on this track. How do we translate this urgency into something real and different, a new moment for reproductive and maternal health? Gitinji, you gave the example of the transport solution that you've all stood up for this problem of women needing to get through roadblocks and curfews and lockdowns. But you also operate at a global level. You talk to people at the World Bank and USAID and the UN. Do you think there's an opportunity here to reframe or re-energize this discussion to take that urgency forward in a new way?
Yeah, thanks, Raj. And I know I have my friends here, David, WHO, we've engaged very closely with how to create an effective private sector engagement platform. And I know, David can talk a little more about that. And of course, for Monique, the GFF is very, very, private sector and the sustainability of private sector in MNZH under GFF is a critical piece of their financing. I want to reflect on two things as I answer your question. One is what Marianne has said around that this COVID is actually preying on existing vulnerabilities. It is creating new vulnerabilities on existing ones. We have been doing programs in semi-arid and arid areas in Africa as AMREF, where we actually have to provide transport vouchers to mothers so that we can overcome the difficulty of that second delay before they get to the hospital. So we work with private partners like Safaricom Foundation, M-Pesa Foundation, and this company actually provides us vouchers through funding and through their mobile technology that we provide to mothers so that when they need to go somewhere, they can provide that voucher to the local bus and get to the facility. So that has been a very effective program and a good example of how private sector is addressing some of these challenges. I want to talk about two other things that I forgot to talk about. The PPE issue that was talked about by Monique has had wider repercussions than we think. On one side, the private sector, recently in Kenya, we had a woman, an uproar because a woman delivered outside the hospital. Actually, she delivered outside East Africa's largest maternity hospital called Pumwani.
You mean physically right outside of it?
Yes, right outside the gate, because her husband brought her to the hospital. And then, there was a worker strike, a health worker strike. And because of the health worker strike, the guard at the gate had the instruction that we are not seeing patients. And he took it literally and said, we are not opening the gate. And in the process, because she was in second stage, she delivered and there was an uproar right outside. And I think it's after the baby came out or just after the baby came out, there were health workers came out to the stretcher and got her in. It's still a big scandal up to now. It happened maybe 3 days ago or so. Now, why were the health workers on strike? Because of these other challenges of COVID, absence of PPEs, for example, and workers saying, we are not safe because we don't have PPE. So why do you want us to provide service when we cannot have infection prevention and control? So the repercussion of absence of PPEs also now, starts to play itself on access to maternal health. And then when you now say, now, how do we now use the private sector to substitute some of these challenges? Now, when you go to the private sector, the introduction of PPEs in care of patients has increased cost of care, because you remember in the public hospitals, the government is actually giving free PPEs to its workers, but the same guidelines that apply to a public health worker who has PPEs from government must also apply to a private worker who is working in the hospital. So while the cost of PPE is factored in the out-of-pocket cost for the mother, or now do you increase the cost, or does the hospital absorb the cost of the PPEs? And when we started, PPEs were costing $110 per set. So who pays for that cost? And therefore you found private hospitals closing down and say, we are not seeing patients because until we know how to cover these costs. So all these are implications. And I think for me to summarize this is to say, the only way out of this for this pandemic and the future one is for all countries, as we agreed last year, to invest in system agnostic UHC, where we know that these challenges of access to care are overcome through demand side financing, not supply side, because we've seen supply side fail. We've seen hospitals cannot buy PPE. They sit and wait for government to send a consignment. But if they were actually doing demand side financing, they would buy the PPEs as they need them. So we need demand side, equity driven, people centered, system agnostic UHC for us to get out of these challenges, is what I would say.
Yeah, ultimately it is one health system. If you're the Minister of Health, maybe you don't personally directly control every private facility, but you have to see it as part of one overall health system that you need to be able to regulate and monitor, get data from, provide service and funding to. Otherwise, half your population in some cases is kind of out of your purview as a health minister. So we have to see it as one system ultimately. Monique, you have these discussions with health ministers. Is this message that Gitanji is putting out there that we should embrace the fruit salad, let's say, is that widely understood at this point, or are we still fighting an uphill battle in terms of convincing people this is one health system?
Sorry, I got so excited that I forgot to unmute myself. But no, he has. There's nobody that can express it better than Gitanji. And I did want to make a few points and maybe also give a plug that we have just posted our strategy refresh with 6 new strategic directions for the next 5 years of GFF for public consultation. And so I would really encourage people to look at that. And what you see there is related to this discussion. And first of all, I think it's really important that we do recognize that no matter how well intended and how constructive donor partners are in this debate, we really need to focus on country leadership. That's the core pillar. What needs to happen needs to be decided and determined on country level in a combination between government and civil society, as a lot of these solutions are very country specific and needs to work in the specific context. And so we very much support a comprehensive country coordination platform led by the government, where government and partners jointly look for solutions to these problems. And then related to the private sector, I think there are 3 points very, very important. One is the demand side financial barriers to access to care for women are enormous, and they've worsened because of this crisis. And so it is really important we see the client, the woman, at the center, and that we think of solutions where we can give women voice around what they want to see in a responsive health system, and that we make sure that we put policies in place where the financial barriers are reduced. Then secondly, the quality of care is an enormous problem in the public as well as the private sector, and we do need very targeted investments to improve the quality of care in mixed health systems. And then finally, we've talked a lot about service delivery in this conversation, but the private sector also plays a really important role in terms of technical capacity, transfer of technical capacity to the public sector, making public services more efficient and more effective. And so we have a fantastic partnership. This is just one example with Gates, the UPS Foundation, and Merck for Mothers, where we're using private sector knowledge on the supply chain to improve the public supply chains, right? And so even with existing resources, if we use that capacity that exists in the private sector and the innovations that are happening in the private sector, and we apply that to a public sector environment, we are also able to make the public services more effective and more efficient. And so that's just another angle where I think the private sector plays such an important role.
Yeah, that's an important one. Thank you for that. And let's get a couple more voices into the discussion. The first voice I want to get in is all of you who are out there watching this. There is a poll question in the platform in Hopin. You can go in there and answer it directly. It's what has most negatively impacted maternal health during COVID-19? We want to get your perspective on this. We'll come back and show those results in just a moment. And in the meantime, we have someone from USAID who's got an intervention that we wanted to share with all of us so the panel can respond to it. This is Monisha Ashok, who's from USAID Center for Innovation and Impact. And I'll just ask the producers to throw up her video.
Hi, everyone. Thank you for the opportunity to participate today and pose a question to this impressive panel. My name is Monisha Ashok, and I'm a Market Access Advisor at the Center for Innovation and Impact in the Global Health Bureau at USAID. The Global Health Bureau is deeply committed to improving the health and well-being of mothers and children and protecting them during the COVID-19 pandemic. We believe in the power of private sector engagement and innovative financing to advance our collective maternal and child health goals and our partner countries' journey to self-reliance. For example, the Global Health Bureau has partnered with the Development Finance Corporation, Merck for Mothers, and Credit Suisse to launch Financing for Moms, which has committed $50 million to invest in companies focused on maternal health. We also have a long-standing partnership with the UBS Optimist Foundation and Merck for Mothers again on the Utkarsh Development Impact Bond, focused on improving the quality of maternal and health services in Rajasthan, India. In June 2020, the Office of Population and Reproductive Health and the Office of Maternal and Child Health and Nutrition launched a $75 million investment, Momentum Private Healthcare Delivery, that aims to improve the ability of local private sector healthcare providers and other partners to improve access to and quality of maternal, child, newborn health and voluntary family planning, as well as reproductive health services. This program also aims to promote more effective engagement between the public and private sectors to enhance self-reliance. The Global Health Bureau has also invested in innovators such as Gradient Health Systems that produces the universal anesthesia machine used in C-sections, and has now pivoted to supporting oxygen and ventilators for COVID-19. Based on these commitments, my question to this panel is, how can we strengthen private sector engagement and specifically innovative financing to attract new capital and new partners to accelerate our maternal and child health goals? Thank you.
Well, you heard the question. I'll just add, that my take to this, which is, this is a different moment than it was. I mean, certainly for USAID, for many other institutions in our field, their importance has been raised. There are new opportunities around funding, and existing funding is being moved around. In every crisis, there is some kind of an opportunity. So how do we take this moment and accelerate out of it in a different way? I don't know if any of you in particular want to pick that up. David, perhaps?
Well, one of the things that we're going to do is we're going to do a couple of things. WHO has not been heavily involved in this area at the systems level for a long time, so we're getting back involved now. So in terms of the work on the private sector, we're about to issue a strategy on working with the private sector, which we're going to send to all our member states to help them better understand how they can work more constructively with the private sector, now in relation to COVID, but post-COVID. The other thing that we're going to do is work much more with our global partners. So we're looking at setting up a working group of all the global partners who work on private sector engagement, including the bank, USAID, the Gates Foundation, etc., and others, so we can get together and work out how we can work better on this topic. Because I think it's fair to say over the last few years, it's been something we worked on at a global level in silos. So we're really interested at WHO in doing something different about this. And also, we're really interested in working with countries. I want to take up the point that was made before about the importance of country leadership on this. We agree entirely. But we also note there's a number of countries who are still reluctant to work with the private sector. And so we think it's really important that we build political will to grapple with this topic, because some countries are really still struggling and still reluctant to work on this topic. And we think it's really important that I think this is a time to actually stop talking about working with the private sector and actually get on with this. This is not a new topic. It's a topic that we've been talking about for quite a long time. And hopefully this is the time. The whole COVID crisis could be the crunch point, and the point where we start to really work with the fruit salad and not just with one fruit in the health system.
Yeah, I think you're right, David. There's been tremendous progress. I mean, the examples you heard from Manisha at USAID, those wouldn't have happened, several years ago. There's been tremendous innovation, partnership. We can point to all of them, but we haven't maybe yet gotten, to your point, to kind of a system-wide global understanding and movement that's required.
It's all really piecemeal. I mean, I'm sorry. A lot of it's piecemeal. We've got to do much more to systemize it. We're going to make this. I mean, if we're going to talk about a health systems response, then we need to address it at the system level, not at the program level. We need it at the system level to look at how we finance health systems, public and private, not just having individual programs financed. At the system level, we need to look at how we integrate the private sector. At the system level, we need to work about how we share data and work better together. So I think that's probably going to be that's the thing that's going to move the needle.
And David, I didn't hear you say MSD for mothers in when you talked about the different partnerships, but we definitely want to be at the table, because Raj, to your question about how do you bring in more private sector financing, is back to the point around data. I think when you are looking for private capital to invest in this, they are looking for data that would support transparency and accountability for how the funds are being spent. They're looking for data so that they can understand, even if it's in the long term, what the return on investment would be, not just from a financial perspective, but from a social perspective. So what's the social return on investment? And to date, we haven't, to David's point, because the integration is not systematized and we don't have connectivity between the different provider networks and the different programs, you're not able to, in any cost-effective or cost-efficient way, understand what the social impact of those investments are. And so until we do that, and until we reduce the transaction costs, that all of you have mentioned, all the obstacles that we're breaking down during COVID, you're not going to get that. You're not going to be able to maximize what private capital, can bring to the table. And I think private capital also helps with the UHC agenda, because there are different innovative financing ways that you link financing to accountability and to performance and to quality. So it's a sustainable dollar because it's renewable, so it really is that S in the SDG. How do we bring private capital to bear so that our efforts can be sustainable for the long term?
Well, and ultimately, if you want to have innovation, you need to have a target you're shooting for. You need to know, what is the cost effectiveness of an intervention? That's how you drive innovation. And we need that certainly to make the dollars go further. Gytinji, I know you want to get in. I just want to mention that we appreciate the poll results so far. They're still coming in, but it looks like fairly evenly split. But in order, people say that the what's most negatively impacted maternal health has been resources, including midwives being diverted away from basic service delivery. After that, decreases in demand as women fear becoming infected in hospitals and clinics. And then the lowest number was for disruptions to supply chains, impacting access to family planning and safe abortion. But these are obviously all three issues, as our participants have noted. Gytinji, please go ahead.
Yeah, this is a really exciting discussion, because about 2 years ago, we started a partnership with one of our private sector partners, just like we have others with Mark for Mothers. And we decided to start a pilot on partnership for primary healthcare. And our our hypothesis then was that primary healthcare is not investable, and we wanted to prove it wrong, that primary healthcare is actually investable. So we created a model which includes blended financing, where we got together, the partner is Philips, and we got together and we went to the county government in one of the counties in Kenya, and we said, let us take 3 facilities that are public health facilities, a health center, level 3, and 3 dispensaries, which are level 2. And we said we are going to improve service. The government is going to continue providing the health workers. They are going to provide the facilities, the physical facilities to us. AMREF was going to do the community engagement, including enrolling people into National Health Insurance Fund so that they have money to pay, and also improving basically the level of service. We have done that, and we have done a feasibility study that shows tremendous increase. Like, for example, service utilization went up 98%. Skilled deliveries went up 78% in these 4 facilities. But these are public facilities where the county government entered into a private partnership with AMREF and a private for-profit company. Now, what we are doing now is that we want to move this and scale it up across the country to more facilities. But let me tell you what the challenge is. The challenge is that the public procurement, and this is important for Monique sitting at World Bank, that the public procurement is not structured to purchase innovation. It is structured to purchase commodities. So it's very easy to order a number of masks. It's very easy to order blankets. But when you order innovation from Mark for Mothers or innovation from elsewhere, the government doesn't know how to deal with that. So we are now in this place where we have funders, including the Dutch Development Bank, who want to put in money into scaling. But we need to sign the privately initiated innovation with the government. And that has taken us almost a year to go through. There's a letter, I need to go to the cabinet. Until these things are unlocked, we can never go to scale. We'll have innovation, we'll keep talking about private partnerships, they'll remain pilots, they'll remain limited until we can address the issue of procurement of innovation within government in a flexible manner.
And maybe that's the opportunity of this pandemic, Gitinji, because finally, because of the urgency and the directives coming from the top of government around the world, some of those red tape blockages are being opened in other areas related to the pandemic. We're seeing the ability to move quicker. We've got to apply that in all of the other health crises that have been pre-existing here in the world. Monique, go ahead.
Yeah, and it's such a great example, and I was familiar with this really innovative program in Kenya, but we see it across the board that it's been very challenging to go from small-scale pilot to large-scale in many of these pilots, right? And so this is a collective challenge we have because we do want to make the impact on larger scale. I wanted to make another point also about the innovative financing, because we haven't talked much about private investors in this panel. And so we had an experience in collaboration with the World Bank Treasury in which they floated a sustainable development bond tagged for women and children's health and mobilized $2 billion in private investments for this agenda. By approaching investors that have a specific interest in the social impact of their investments. And this is something that we did 2 years ago, but I do think there is more opportunity, particularly now the world is so aware of the importance of health and the security issues around health. To really look at that group as well to see whether there are other opportunities to put in place those programs that really raise resources on such a large scale that we can really bring an impact to what we can do.
Thank you, Monique. Yeah, I'm looking at the time. It's been such a fantastic conversation. I want to make sure we do get in one other voice we have from India. That video we tried to play earlier and you couldn't hear. We're gonna bring that back, and then Marianne and I are going to come back again to kind of close up the conversation. So I know everyone at home is applauding this virtual panel. I wish we could be doing it in person, as you said, Monique. But I'm so happy we've had the chance to at least convene this way, and the insights that Gitinji, you and David and Monique that you've all brought here have been so important to the discussion that we're having today at the UHC Pavilion. So thank you for being a part of this. And I'll ask the producers to go ahead and cue the video.
I am Dr. Jaideep Tang from Mumbai, India. I am the Secretary General of FOXI, that's the Federation of Obstetrics and Gynecological Societies of India. In India, the government as well as the private sector are both fully committed to achieving universal health coverage. A significant proportion of care is delivered by local private providers. Over 50% of all women in India seek maternal health and family planning services from private providers in India. The role of the private sector in offering high quality, safe, and respectful SRH services to women and adolescents is self evident, and given the size of the population it caters to, extremely important and significant. Even during the pandemic and through the lockdown, several providers in the private sector, like me, continued to provide services to patients. The COVID-19 pandemic has shown us that multi-stakeholder response and the force multiplier effect of these synergies is crucial. Public-private partnerships represent a critical component in filling the gaps, both of human resource and infrastructure, that exist in modern-day healthcare. FOXI, a professional association in India, is already leading the way via an initiative to implement and assess WHO evidence-based standards of maternity care across the private sector through our initiatives, Manyata, and a Government of Maharashtra FOXI-supported initiative, Laksh Manyata. There is an urgent need to bridge the trust deficit and look beyond monetary incentives to increase private sector involvement. The government, for example, can consider developing incentives to encourage private participation under a unified and resilient health system, where both sectors compete on equal terms under a framework that regulates each fairly. For example, transparency in administrative processes, reducing the steps for compliance, and reasonable laws and policies that are not skewed towards any one side, and not treating every adverse outcome as medical negligence could increase the private sector's incentive to participate. An example could be a single window system for regulatory compliance. This will not only incentivize the private sector, but will also be cost effective for the government. It is vital that the government as well as the public at large recognizes that healthcare providers also need to be safe and shielded from abuse. Moving forward, a thorough mechanism that revolves around fair incentivization and equally important recognition must be embedded within the current PPP framework for SRH services. Our government understands this and has also shown interest in engaging more with the private sector in a recent WHO Government of India Partners Country meeting. I believe that this is recognition of the fact that sustainable and long-term partnerships in general, and PPP models in particular, require a level playing field and the creation of win-win outcome for all the partners.
Yeah, that was interesting to hear, Marianne. I've had the chance to meet with and interview health ministers in the past of India, and the scale of the health challenges there. Just thinking about the overall population, how big their insurance scheme is. It's really mind-boggling how many people are affected when you make a policy change in a country like India. We've had a good discussion, I think, today. I've learned a few things, but I want to bring you into it, Marianne, because David kind of gave us a challenge, which was, we talk a lot about one-offs, but still we don't have the system-wide change we need to see. And I wonder what your take is on how we get closer to that system-wide change, and whether you think this moment, the urgency created by COVID, could help to spur that. What is your call to action for people who are following this?
Thank you, Raj. I think it has to. And I am so appreciative of my colleagues on the panel, for sharing, the exciting work that is happening and our ability to surface it on this panel. Now I think what we need to do is memorialize it, and as David mentioned, think about this from a systemic way, so these these best practices become institutionalized, become adopted and translated at the country level. That's what I'm hoping can happen, because again, none of us should be reinventing the wheel. And we are learning during COVID, just how impactful collaboration between public and private sector can be, for that woman who needs to give birth right now.
Gitanji, you're eminently quotable. You've given us fruit salad today, which we will, I'm sure, all be taking forward and using. And in my book here, which you see over my shoulder, I actually quote Dr. Gitanji Gaddafi for saying that we don't do UHC because we are rich. We do UHC because we are poor. The system that we have, integrating it, making sure it's robust, that it exists in good times and when there are bad times like a pandemic, we do this because this is the most effective way to actually address these issues of human health. I thank all of you who participated in this. I thank Marianne and all of your colleagues at MSD for Mothers for your work every day and for the partnership with Devex, and all of you who've been joining this UHC Pavilion virtually today. It continues from here forward. I will be rejoining in just a moment and introducing the next segment, and look very much forward to seeing all of you again. So thank you. A big virtual applause from my side.